Thank you very much, John. I'm going to make a set of observations mainly about, I suppose, the social security side of the intergenerational report and related issues. And I think that the issue of sustainability is very important, and I should also start by saying I think that the budget challenges that we face also need to be addressed. But I think sustainability needs to be looked at more than just in terms of the balance between spending and taxing. And that is that what's a sustainable policy is one, and I think that the experience of the last year since last year's budget has shown that the issue of distribution is extremely important. And I think that was I took that, the question from George to the Treasurer, raised that. And I'm not suggesting that the intergenerational reports in future should project the distribution of income out into the future, because I think that would be piling assumption upon assumption in a way that's makes the whole exercise even more questionable. But I think that it's pretty clear that underlying some of the alternative projections in the intergenerational report are distributional outcomes. And it's pretty clear that even if one can't project what the Gini coefficient would be, that there are very difficult choices to be made. Now, the assumption about real wage growth, as I take it, suggests that 40 years from now, real wages before taxes would be about 75% higher than they currently are. So, on average, working Australians will be much, much better off. All of the IGRs have, however, for payments for people of working age, so New Start in particular, have assumed that you have the continuation of price indexation. So basically, there was some minor increases in the real level of New Start associated with a couple of changes such as the GST and the clean energy compensation. But basically, the real level of New Start hasn't shifted since about 1995. So what we're saying, if we continue the assumption of price indexation of New Start, is that in 2055, the real level of New Start will be about the same as it was in 1995. I think real wages have... so what will happen is that back in 1995, New Start was about 24% of average wages. It's about 19% of average wages. If we flow through these assumptions, in 2055 it'll be about 10.5% of average wages. So you'll have the continuing impoverishment of people on unemployment payments. And as has just been mentioned, one of the underlying assumptions is that unemployment never goes below 5%. So we'll have 5% unemployment, and if we believe that no government is ever going to increase the real level of New Start in the future, we'll have people on 10% of the average wage. I don't think that's going to happen. I think that will be politically unsustainable. I hope it'll be politically unsustainable. Similarly, basically because of changes under the Labor government between 2007 and 2013, family payments are now indexed to prices rather than wages. So they also shrink over time. That will also have implications for child poverty. If we take the assumptions built into the latest IGR, if the government's policy changes that they proposed in the last budget, the change of indexation of pensions, continued to 2055, and this isn't in the IGR, but if you had price indexation for the next 40 years, pensions would be about 16% of average wages. That would be lower than it has been at any time in the last 45, 50 years. I don't think that's going to happen. So what that means is that the fiscal sustainability challenge, if we don't believe that we're going to impoverish the poor, is that the challenge is bigger. we will want to be spending more money on the unemployed. We may want to be spending, more money than is in the assumptions on families, and then there's the vexed question of pension indexation. Now, these are just the logical consequences of the indexation provisions. Now, as I said, I'd hesitate to project forward the Gini coefficient in any sense, but clearly there are massive distributional implications underlying the assumptions in these projections. And as I said, in some senses, I don't think that they're realistic. So what are some alternatives? I think that raising the pension age is obviously would have some attractions. However, having said that, I think that we have raised the pension age for women from 60 to 65 over the past, since the mid-1990s. That has had a very significant impact on the number of women aged 60 to 65 receiving payments. If you go back to the mid-1990s, around 60% of women aged 60 to 64 were receiving age pensions. There are now 0 women aged 60 to 64 receiving age pensions. Around 20% are actually now receiving disability support pension instead. So there's been a shift. That's part of the reason for the increase in the numbers on disability support pension. But in aggregate, the share of that cohort have gone down very significantly. But I suspect that as we move forward, as in raising the pension age to 67, and then if it's finally legislated to raise it to 70, that those effects are going to become less strong, mainly because we know from the survey of disability ageing and carers that disability rises with age. Now, sort of raising the pension age reduces what's called the pension wealth, or the public pension wealth of the population. There is a gradient by income. I think Andrew Lee calculated with a co-author that the difference in life expectancy between the poorest 20% of the working age population and the richest 20% of the working age population is about 6 years. If we raise the pension age to 70 on current life expectancy, Indigenous men don't live that long, so there are significant issues to be considered. However, offsetting that is the fact that we're the only OECD country that actually excludes most of the richest 20% from the age pension. So in fact, that potential inequity will not be anywhere near as significant in Australia as it might be elsewhere. But I think that what the issue that raises is that we do need a robust safety net for people to fall back on, because clearly not everybody, people in my line of business or in our line of business can probably easily work till the age of 70 if we want to, but lots of people don't have the sorts of jobs that we do. And as I said, rising disability with age suggests to me that we need adequate disability payments, adequate unemployment payments for people who, at those ages, even if they are still in the labour force, might have significant difficulties in finding employment. Thank you very much.
Hi everyone. The DSS, for those who are wondering, is the Department of Social Services, not a spy agency. I thought I'd try and do 4 things today. I'd explain the Department of Social Services' basic policy approach to these questions. Then I thought I'd talk a little bit about what the IGR means to us. I'd touch on some policy structural and dynamic issues that are guiding our work, underpinning our thinking, and then leave you with a couple of thoughts for policy. The policy mission of my department is to improve the lifetime well-being of people and families in Australia. We've got responsibilities from the beginning of life to the end of life. We do this in a frame of encouraging independence and participation. We recognise that people and families have a responsibility for their own well-being. And importantly, and echoing some of Peter's comments, we give policy priority to those who are most likely to have the poorest lifetime outcomes. Our focus is on the lifetime impact of policy. We recognise that the whole of the life course is important and that actually well-being trade-offs occur across life. We also recognise that policy is built on an implicit bargain between generations. The IGR highlights important aspects of that bargain. For us in DSS, IGR 4 provides some important reminders about the policy dynamics in Australia. First, we need to ensure that policy remains sustainable across generations. We've got to maintain that implicit intergenerational bargain. Second, our ability to be generous socially depends on our ability to grow economically. Third, we need to plan for the changing demographics in our society, and that is as much about service design as about dollars. Fourth, all three Ps are important: productivity, participation, and population. But for us, we have particular responsibilities around participation. Fifth, policies for older Australians play a major role in getting these balances right. Particular focus of my department, we're responsible for the aged pension and the aged care system. All up, DSS is responsible for about a third of the Commonwealth budget. It's dominated by those two expenditures. Australian policy is deliberately structured to be most generous to people who are retired. That's in keeping with all modern economies. We are deliberately structured to be most generous to people who are retired. We encourage self-provision through superannuation, but no longer demand it through work. We provide a generous safety net through the age pension. We provide high quality and highly subsidised health and aged care systems. And we, primarily through state governments, provide substantial concessions for day-to-day living costs. This generosity means that consumption actually rises in retirement. Here, Peter McDonald and I have a slight different interpretation of his charts. I'd say on average, after retirement, consumption slightly higher than during the working life phase. Irrespective of that debate, what is certainly true is as we age, taxpayer support funds an increasing proportion of our consumption. And interestingly, wealth, asset drawdown, does not appear to play the role we might have thought, including with aged pensioners. These dynamics underpinned a key part of our Minister, Minister Morrison's recent speech to the Press Club. He, like the Treasurer earlier today, talked about an ageing boom. The challenge presented by Minister Morrison was to encourage older participation and encourage older people to use their own wealth. That is obviously a focus for DSS. Final thought. When we think of retirement, we generally think of it as one phase. Yet our needs and spending changes dramatically as we age. Perhaps as policy advisors, rather than thinking of one phase of retirement, we should think of 4 phases: pre-retirement, healthy retirement, ageing, and end of life. In each of these phases, our behaviours and our expenditures and our needs are very, very different. Perhaps by thinking of policy through that lens, we would actually get a better balance between the money side and the service side. Leave that as food for thought. Thank you.
Okay, firstly, I would congratulate John and CEPAR for putting this event on, and the Treasurer for his openness and for what I believe is the best IGR to date for all the comments and criticisms that I would have for it. I'm going to start by making a few brief comments about the IGR this time, and then go on to some CEPAR evidence, because that's one of the best things that I think CEPAR brings to policy debates. In other words, how we can not just identify these challenges, but how we can respond to them constructively. And lots of things we can do with knowledge and good ideas. And I'll do that a bit for health, and then I'll go on to a little bit about retirement. And I'll finish off with what looks like a soft thing, which is attitudes, but I believe that sets the framework within which policies can be considered. Okay, some introductory comments, and I've been observing these IGRs, indeed, back to the razor game that preceded it, and to say that this one is very valuable, and I'd invite people to look particularly at the foreword that the Treasurer has written. He talks about a social compact between the generations. I would add that older people deeply feel the generational investment in those who come after them, and not just their children, but all of society. It's a basic social fact. And I note that the focus is on productivity and participation, that the constructive responses, and that older people are part of those solutions, whether they be called grey armies or whatever, but they're part of the solution. And that also remind people this is limitations to the IGR. It's projection, not prediction, and it's fiscally focused. It's not about all the relationships outside of the fiscal, the monetary, dare I say, pretty narrowly, the Commonwealth monetary, but that's a whole other question. Okay, some also like healthcare costs, what a big improvement this time. Healthcare costs are attributed much more sensibly this time. There's recognition that there's increasing utilization, increasing costs of supply, these apply for all age groups, not just old people. And that was not the case previously. It was population aging, you old people. It's a little different now. Okay, some CEPAR evidence, and mainly from our healthy and productive aging research. I'd acknowledge that Karen Anstey at our center here at ANU and Kathy Gong have been central to this work. A few comments here is that we really do have increasing life expectancy. And not only that, we have increasing disability-free life expectancy. And further, that life expectancy is occurring very much from age 65 onward. This is quite a new phenomenon in the globe, and on many implications of this. One I would point out is that it is still open for change. The idea of competing risk, people know about that if one thing doesn't get you, something else will. So that even if we eradicated all of cardiovascular illness, cancer, or whatever, we might buy 5 to 7 years or something. So we're not looking at huge foreseeable changes in life expectancy. There are some uncertainties here with the baby boom coming into later life with very different lifelong profiles of patterns and so forth. But yet so far, disability-free years seem to be keeping up. And here are two big ideas for you. We've got plenty of evidence behind how to achieve these things. One, there's a third age. And that third age is something between a usual age of retirement and becoming frail. Sean was basically talking about that. What are we going to do with this productively, usefully, and for quality of life? And the other big idea here is one of aging well. People in their own eyes are aging well. And we do have research which shows that, first of all, aging well to them means you stay in the community, you stay independent. Oh, first of all, you stay alive. And you feel well. And we have some longitudinal predictors that show how you achieve these things. And some of those are, yes, look after your health in terms of not having health conditions, nutrition, social support, not smoking. And I'd point out further there's great variability between men and women, quite different risk profiles and resources for the two, and that much of this leaves out Aboriginal people, most of whom never get there into aging. So we have these ideas. Another big idea is about health as an investment, not just an area of expenditure, but as an investment for what we want to do. If it's good enough for the World Bank, it ought to be good enough for Australia. We can show the benefits of health investments in terms of being able to work, in terms of being able to produce in families and so forth. The idea that you can be, in some ways, flawed and still age well. There's the idea of aging well with chronic disease. People with chronic diseases are usually going quite well, and there's a lot they can do to improve and to moderate that. So one of the messages here, which Michael Moore was raising earlier, is that we don't want to forget older people in health promotion efforts, and we don't want to do so because we have negative attitudes toward aging and can't conceive of those benefits. And also importantly, I just mentioned it now because it's not my area, but Karin Anstey, who's here, is leading the world in lots of ways and looking at cognitive health with aging. And just think what an enormous resource that is for negotiating through aging and for being able to contribute and so forth in the kind of economy and world we have these days. Okay, so just to start to finish off, a little bit about retirement. The process generally is quite positive for people, except for those who are sick and therefore retire. The most at-risk group are working class men who are inclined to not get their physical activity anymore and not to stay so socially engaged. Productivity goes far beyond paid work. We have a good CEPAR working paper on that with Vanessa Lowe, which shows the many contributions that older people make beyond the fiscal, beyond the paid work, and these are really real as part of the intergenerational relationships. And the importance of work and caregiving. So the way older people indirectly contribute through supporting middle-aged people who are in the workforce and with their families and so forth. I'd point out through our comparisons that the UK, Canada, and New Zealand are far ahead of Australia in this very important area. To start to finish off, a few things about attitudes. We ran a big national survey of attitudes back in 2010, and we found many things there. Overall, the intergenerational bonds are coming out very strong. Overall, there's a lot of deep feeling that older people not only deserve things later in life, but, well, to me, a little surprisingly, they don't get enough. That was the attitudinal set nationally at that time. Maybe things will change when we redo this survey over this coming year. And the area where older people came out worst was what I would almost call ageism in the workforce, expectations that older people could not contribute as much as younger people, all of which has largely been shown to be less correct. So to finish off, a few things here. One is that this is the age groups. The really important thing is how things happen through life, how advantage or disadvantage accumulates and the consequences later in life. Also, intergenerational transmission of families that are in deep poverty between generations and how this continues. How can we break into that? And I'll finish off with one area of particular interest for me, which is about aged care, and to point out how limited the area of projection is, because the purpose of projecting things is we want to change it. And if we projected aged care, as it's called, back in 1965, 50 years ahead, who would have foreseen the world we have now? And I would say that the world we have for aged care 50 years from now isn't going to be adding up of nursing homes and bits of community care. It's going to be entirely different. So we have to think about that, how we're going to change that. And I'd end up by just making the comment that a lot of this, it's sort of implicitly, not in the IGR directly, the language has improved this time around, but it implicitly says that older people are a drag and that they're holding back Australia's advance. I would comment that standards of living in Australia have been improving. They're likely to improve considerably. And I'd ask the rhetorical question, should earlier cohorts and older people benefit in the improvements for the nation? Thank you.
Yes, I've got a few slides, and I'll perhaps give a very brief overview of the IGR and then give my own comments. There's no better quote to perhaps bring together health and sort of the fiscal thing than the Benjamin Franklin's quote, as you can see. So just very briefly, in the key messages on health, there's obviously this notion that we're clearly living longer in our predictions of life expectancy, and they've moved from the sort of standard period life expectancy to cohort life expectancy projections to try to take that into account. Consequently, or the projections on real health expenditure, that they double over the next 40 years, although, as has been pointed out, perhaps they're less or severe in terms of a proportion of GDP than previous IGRs. And I think that what it makes very strongly, which perhaps Hal Kendig made before, is the key drivers aren't what people normally think, which is the ageing and demographic change, but sort of technological change and also demand for more health as our incomes rise. So just very briefly on the longer life expectancy, all I'm going to talk about here, of course, it's linked to potentially healthcare. That's the chart, and those are the projections of a male and female age today will live, or could be expected to live to over 90 years based on extrapolating the current reductions in mortality. Perhaps behind that, and it's kind of an interesting graph over here, which I've calculated myself, and if you take basically the period life tables over the course of the 20th century, what you see is the 20th century was very much in two halves. The first half of the 20th century, the gains were all in the sort of under 65s. There were almost no gains actually in life expectancy over 65, and then something perhaps unexpected happened from the late 1960s, early 1970s, is the gains started occurring and persistently of about a year, a decade in the over 65s, and there's still been some reductions in the under 65s, although there's a point where you can't actually reduce things much further. Now there's clearly potentially, though, explaining the over 65s, you've got to look at some of the sort of medical technologies, particularly in cardiovascular risk, and of course sort of declines in smoking. And I suppose, is the future going to look like that? Well, we've got to find another major way to reduce mortality, particularly in cancer. That may or may not occur. But I think it's very wise to be conservative and make, particularly if you're worried about the sort of fiscal cost, to make the assumption that these trends will continue. Interestingly, as was mentioned before, there's work I've done with the Andrew Lee, when he was a professor here at the ANU, trying to calculate life expectancy for different socioeconomic groups. And clearly almost all the IGR, as far as I'm aware, except it does have a table looking at Indigenous versus non-Indigenous life expectancy, making the very sort of stark point that there's about a decade difference in terms of between Indigenous and non-Indigenous, the life expectancy gap. But what we calculated were broader inequalities, and as you can see, the inequalities for having less than 12 years of education and greater than 12 years is around 4 years, compared with the 10 years, as I mentioned before, for Indigenous versus non-Indigenous, and the highest quintile versus the lowest quintile is around 5 years. And so these are it does seem to me this is an important question if one was to enhance the IGR, is to start having a look at the distribution and the distribution of life expectancy. and sort of what that means for policy. In terms of government-funded programs, obviously, we're talking about here Medicare, pharmaceuticals, contributions to public hospitals, and the private health insurance rebate. I think very crucially, everyone who kind of looks at drivers of healthcare expenditure inevitably say, well, most of it is actually down to incomes, where we demand more health than we have in the past, technological change, some stuff around chronic disease, although clearly there's not much evidence at the moment that that's increasing, as it were, in terms of the healthy life. There's a change in the trend of healthy life expectancy, or increase in healthy life expectancy, but that may change in the future. And as I said, the demographic factors are only about 20% of the overall projections. And here is the projection of the 2,800 to the just over 6,000 in terms of the real projections in health expenditure. If you break those down clearly, and they're basically, as far as I can see, projecting what's happened in the last few years, Medicare is the area where there's the greatest growth component. Pharmaceuticals, which was in the first IGR the sort of standout growth, has now been has now fallen back, and that's given recent sort of reductions in growth rates. Public hospitals, there's clearly this sort of stated policy change to basically, given the substantial increase in the last few years, to index from 2017, 2018. So basically, there will be not much great reductions, and the PHI is predicted to be fairly stable. I suppose I perhaps have two kind of general points. One back to the issues about perhaps taking into account not just looking at the average, looking at the distribution. I think that's pretty important. One, I think you can do better forecasts by looking at the distribution, particularly if expenditure differs across groups. And I take the case if high health expenditure is amongst those with the lowest life expectancy, which often it is. If you actually get a good predictor of how long someone's going to live, it's how much we're spending on them. Often that may have quite a different sort of impact on your projections than if you had if the longest life expectancy had the highest expenditure. So I think if nothing else, you might be able to produce better forecasts by disaggregating some of these projections. But also clearly, and this has perhaps been raised, is it perhaps fair, given that there isn't a uniform life expectancy in Australia currently, is it fair to have a uniform policies, in particular something around pension age? And I've raised the issue about education. If there's a 4-year gap in education, is it fair to have a constant sort of pension age or age eligibility? And perhaps there also needs to be a broader dialogue, given that we've got an objective, a very clear bipartisan objective to close the gap in Indigenous versus non-Indigenous life expectancy. Is there an objective of Australian governments to actually close the gap more generally? And obviously that's a big policy issue. Perhaps on the other side is perhaps the issues around potentially, I'll ignore raising revenue because that's a more general question, but controlling health expenditure. I'd say there's really, the obvious things to look for, which perhaps could be bought or could be developed from the report, is a much more sophisticated process of health technology assessment. I think particularly in the hospital system, where if you think at the Commonwealth level, there is both the pharmaceutical benefit scheme and MSAC for looking at which technologies we invest in pharmaceuticals, and also on the MBS. There is no comparable systems in state hospital systems, and they desperately, I think, need something comparable, but maybe that could be done at a federal or intergovernment level rather than have each individual state have its own health technology assessment process. Part of that, I do think, also is the one word is disinvestment, which is stop paying for ineffective medicine. Every dollar of waste is a dollar of income, which means that does require evidence and I think a strong will from government to stop doing things that we know. But there are an increasing list, I think, of evidence of medical interventions that aren't doing any good and cost money. I think we need to think about incentives. People talk about price signals. Well, where we do have price signals in the system currently is in pharmaceuticals, but it's a uniform rate. Most people are paying $6. There's a question about whether you want to have different payments for different drugs. Beyond that, broadly, I think there is a question about whether we have an explicit rationing, and I think that's the day when someone gets up and says, well, there's an effective healthcare intervention, but we can't afford it because it's not cost effective. And that's, I don't think, a day we've reached yet, but it is a discussion we need to have. And I think perhaps that comes to the final point, which was recommended by the Audit Commission, is to have caps, whether we have a cap on a program, which forces very quickly there to be some explicit rationing. Just to put these all in perhaps these fairly sort of just general terms into a very quick case study. This is the amount that is being spent on different types of diabetes drugs in Australia, mainly for all for type 2 diabetes. As you can see, metformin, was a widely used drug and regarded as highly effective, currently costs about $10 a script. Another generation of drugs, the sulfonylureas, cost around $14 a script, and the new agents cost around $60 a script. And what you can see is the dramatic rise in expenditure very quickly and very rapid adoption by Australian doctors of the new technologies, which aren't necessarily proven to be that much better, and often what emerges over time is a range of some things are better about them, but there are certainly some significant side effects with the newer drugs. Now, interestingly, if you add the area under that curve of the new drugs, you end up with about $500 million worth of expenditure. If you look at the comparable expenditure in New Zealand, it is nothing. They have not spent a single cent on those new drugs. And so I think it's a classic case study where we can start to say, have the people in New Zealand with diabetes really suffered from not having access to those new technologies? But that's the sort of discussion that we will need to have over the coming years. Thank you very much.